You know, we spend so much time obsessing over our faces. We're in the mirror, we're looking at wrinkles, worrying about symmetry,
Right.
but we almost never stop to think about the actual machinery under the skin, the stuff that makes a smile or a frown even happen.
Well, that's pretty much the rule with human anatomy, isn't it? It's completely invisible and, unappreciated right up until the second it becomes a problem.
Exactly. And today we are looking at a very specific, and I mean a very high stakes problem. Imagine you wake up one morning, you find a small lump just below your ear.
Okay.
It doesn't hurt, it's barely noticeable. So naturally, being a busy person, you ignore it.
Which, to be fair, is what most of us would do. We're wired to react to pain, not to silence.
Right, but let's say a month goes by, then 6, then a year, and it's still there. Maybe it's a tiny bit bigger.
But life goes on.
Fast forward 2 years, suddenly you're sitting in a surgeon's office, and this painless little bump has become the center of this huge anatomical puzzle. Today, we're deep diving into the world of parotid swellings.
It might sound like a really niche medical topic, but I promise you, this is a masterclass in detective work. It's where geometry meets biology in a very, very dangerous part of the body.
And to guide us, we've got a great stack of source material. We're looking at these really detailed clinical case presentations.
Basically, the raw files.
Yeah, compiled by medical students in college, working with their senior surgeons.
And what I love about these sources is that they are not dry textbooks. They're like transcripts of real-time clinical thinking. You get to follow the doctor's mind as they go from, what is that, to a diagnosis.
And then to a surgical plan that is honestly a little terrifying in its precision.
It really is.
So the mission for this deep dive is to unpack that detective work. How does a doctor tell the difference between a benign annoyance and a malignant threat? And why does the surgery involve navigating a nerve that controls your entire face?
It's biological investigation meets high-pressure structural engineering.
Okay, so let's get into the cases. We have 2 patients in our sources, and they are remarkably similar.
Right. We have a 52-year-old woman and a 50-year-old housewife. Both come in with a swelling below the right ear.
And the timeline for both is identical, 2 years.
2 years of slow, steady growth. In one case, the notes say it started as like a 2 by 2 centimeter lump.
So the size of a grape.
Exactly.
Yeah.
And over 2 years, it progressed to a 4 by 6 centimeters. So now we're talking about something more like a small plum or an egg.
But the thing that really stood out to me in the notes was that these women felt fine. No pain, no fever, no trouble swallowing. They were perfectly healthy, except for this thing growing on the side of their face.
And that silence is actually the first huge clue. In the world of the parotid gland, what isn't happening is often just as important as what is.
So the lack of pain is a big deal.
It's significant, yes. But the biggest sigh of relief for the doctor, the thing they checked first,
Yeah.
was that they had no facial paralysis.
Why is that the number one fear?
It's all about the facial nerve. This is the wire that controls, well, everything. Smiling, closing your eyes, frowning. And it runs directly through the parotid gland.
It's not just near it.
No, it's inside it. So if a tumor is malignant, an aggressive cancer, it has this tendency to infiltrate and just destroy that nerve.
So if a patient walks in and they can't smile on one side, or their eyelid is drooping.
Yeah, then you are almost certainly dealing with something nasty that has already eaten into the wiring. But these women, normal facial movement.
So slow growth plus no paralysis, that generally points towards something benign.
Generally, yes. The rule of thumb that doctors use is that slow growing and painless usually equals benign. On the other hand, if a patient has a lump that just blew up, it's hard as a rock and it hurts.
That's a red flag?
A massive red flag for malignancy.
Okay. Now, there was this one question the doctors kept asking that I found really specific. They were obsessed with it.
I think I know which one.
Does the swelling get bigger when you eat?
Yes, the mealtime clue. It sounds like such a strange question, but it's pure physiology.
Because the parotid is a salivary gland. It makes spit.
Exactly. It's a factory. When you smell food, or even just think about a lemon, your parotid kicks into high gear to produce saliva. Now imagine there's a blockage in the delivery pipe.
Like a stone. A kidney stone, but in your face.
Essentially, yes.
Yeah.
A silolith. If that duct is blocked, the gland makes all this saliva, but it has nowhere to go. So the gland just balloons up.
And it would be painful.
Very painful. And it happens every time you sit down for a meal. Then an hour later, it slowly goes back down.
So if the patient says, yeah, I look like a chipmunk at lunchtime, you're thinking blockage, not tumor.
Precisely. That's a plumbing problem. But in our cases, both women said no. The size was constant. And that tells the doctor, this is not a backed up pipe. This is a solid mass, a neoplasm.
Okay, so we've ruled out a stone. We think it's a tumor. Now the detective work shifts to what kind of tumor. And this is where they start asking about lifestyle.
Smoking and alcohol. And this is a great example of pattern recognition in medicine. We usually think of smoking and, lung cancer, obviously.
Of course.
But there is a very specific type of parotid tumor called a Warthin's tumor that has a super strong link to smoking.
Really? Just that one type?
It's the classic association. Warthin's tumor, or if you want the full name, papillary cystadenoma lymphomatosum.
I think I'll stick with Warthin's.
Good choice. It's almost exclusively found in smokers. The theory is that the smoke irritates the lining of the ducts inside the gland and triggers the growth.
So if our patient was a 60-year-old man, pack a day for 40 years.
You put Warthin's at the very top of your list. But our cases today are non-smoking women. So statistically, Warthin's drops way, way down the list.
But they also ask about family history, things like lymphoma or tuberculosis.
Right, because you have to rule those out. Tuberculosis can cause lymph nodes in the neck to swell up and get matted together, which can look exactly like a tumor. And lymphoma, well, that's a cancer of the lymph nodes themselves. You have to check.
Okay, let's move to the physical exam. This is where I felt the sort of art of medicine comes in. The sources talk about this very specific way the doctor looks at the patient.
Yes, you don't just stand in front of them. The standard maneuver is to stand behind the patient.
Like looking over their shoulder.
Exactly. You look down from the top of their head, it gives you a bird's eye view. You can see the asymmetry. You can see how the swelling pushes the earlobe out.
The lifting of the earlobe, I saw that phrase.
It's a classic sign. The parotid gland is tucked right behind your jaw and under the ear. If a tumor grows in the deep part of it, one of the first things it does is push that earlobe out and up. You can miss it looking straight on.
And they mapped out these really strict boundaries for where the gland is.
Oh yeah, it's the danger zone. Superiorly, it goes up to your cheekbone, the zygomatic arch. Inferiorly, down to the corner of your jaw, the angle of the mandible. And in the back, it hits that hard bump behind your ear.
The massoid process?
That's the one.
And there's a trick to finding it on the surface.
There is. You draw a line from the tragus, that's the little flap of cartilage in front of your ear canal, down to the corner of your jaw. The gland sits mostly below and in front of that. But you can't just poke the outside.
Right. You have to put a finger inside the mouth.
The bimanual exam. It's absolutely essential. One gloved finger inside the cheek, the other hand on the outside. You're basically sandwiching the gland between your fingers.
And what are they feeling for inside?
2 things. First, you're checking to see if the tumor goes into the deep lobe. That's the part that pushes up against the wall of your throat. You can sometimes feel it bulging.
And the second thing,
You're feeling for Stenson's duct.
the saliva tube.
Yes. And here's a fun anatomical fact for you. Stenson's duct opens inside your cheek, right opposite your upper second molar.
I am 100% checking that with my tongue right now.
Everyone always does. A doctor feels there to see if there's a stone, like a little pebble, or if there's pus coming out. But in these cases, the duct was normal.
So, in our cases, the exam found a lump that was described as firm, mobile, and well-defined. Can you translate that?
That is the holy trinity of benign tumor descriptions. Firm means it's solid, not a fluid-filled cyst. Well-defined means it has clear edges.
It's not all blurry and mixed in with the muscle.
Exactly. And mobile is the most important one. It means you can wiggle it around a bit.
Why is wiggling good?
Because if it's cancer, it often acts like tree roots, digging into the skin and muscle and everything around it. It becomes fixed, stuck. If you can move it, it usually means it's encapsulated, contained in its own little sac.
So firm, mobile, well-defined.
That is the textbook presentation for something called a pleomorphic adenoma.
That sounds complicated.
It is the most common benign tumor of the parotid. Pleomorphic just means many forms, because under microscope it looks like a chaotic mix of tissues. But for the patient, it's the best case scenario for a tumor.
Okay, so we have a likely diagnosis. Benign tumor, pleomorphic adenoma, so we just need to cut it out. Sounds simple enough.
And that is where you walk straight into the minefield.
The facial nerve.
The facial nerve. This isn't a nerve that runs near the gland. The parotid gland is basically wrapped around the facial nerve like a sandwich.
So to get the tumor out, you have to dissect the bread without touching the filling.
Perfect analogy. The nerve splits the gland into a superficial lobe and a deep lobe. Most tumors are in the superficial one. But to remove it, you have to slice right down to that nerve layer.
And this nerve controls everything.
Everything you see on the face. It exits the skull and then branches out like a goose's foot. They call it the pes anserinus. Branches go to your forehead, your eye, your cheek, your mouth, your neck. If you cut the main trunk, the patient wakes up with half their face paralyzed.
That is terrifying. Is that why the doctors did that silly faces exam you see in the notes?
Exactly. Before you ever pick up a scalpel, you have to document that the nerve works. Close your eyes tight, puff out your cheeks, show me your teeth.
It sounds funny, but it's really a legal baseline.
It's documentation. You have to prove the nerve was working before you touched it. Because if they can't do those things before surgery, it changes everything.
It means the tumor's already done the damage.
Right. It means it's probably already compromised the nerve.
I saw a really nuanced point in the notes about infiltration versus spread. What's the difference there?
Oh, that's a crucial distinction. Infiltration is microscopic. It means tumor cells are eating directly into the nerve fiber, right where they sit. Spread usually means paraneural spread.
This sounds worse.
It is. Imagine the nerve as a highway. Some cancers, particularly a villain called adenoid cystic carcinoma, use the nerve sheath like a road. They travel along it, moving far away from the main tumor.
Like a train on a track.
Exactly. The tumor might look small, but the cancer cells have traveled 3 inches up that highway toward the brain. Adenoid cystic carcinoma is notorious for this.
Yikes. Okay, but for our patients, the nerve was fine, so the plan is surgery. A superficial parotidectomy.
Correct. The tumor's in the superficial lobe, so you remove that whole section of the gland, leaving the nerve in the deep lobe behind.
And the incision. You can't just slice down their cheek.
No, surgeons are very conscious of this. They use what's called a modified Blair's incision. It's designed to be hidden.
Describe it for me.
It starts in front of the ear, curves down and around the earlobe, hiding in that natural crease, and then snakes down into the neck in kind of an S shape.
Why that specific shape?
Well, it follows what are called Langer's lines, the natural tension lines in your skin, so it heals with a minimal scar. But it also lets the surgeon peel the skin forward like a flap to expose the whole gland.
And once it's exposed, what's the first move? Do they go for the tumor?
Absolutely not. The sources describe this as the holy grail of the surgery. You do not touch anything until you find the facial nerve trunk.
Find the main wire before you cut anything else.
You find that main trunk where it comes out of the skull, in a spot called the stylomastoid foramen. Once you have that secured, you painstakingly trace every single tiny branch out, literally peeling the tumor off the nerves. It is tedious, high-stress work.
If they accidentally nip one.
A tiny branch, you might get some temporary weakness. If the main trunk is cut, you're looking at permanent paralysis. In really bad cancer cases, they sometimes have to sacrifice the nerve to get all the cancer out.
And then what?
Then you're looking at nerve grafting, taking a nerve from the leg or neck to try and splice it in. But obviously you want to avoid that at all costs.
One thing that surprised me, they didn't do a biopsy first. Don't you usually stick a needle in to confirm what it is?
Great catch. In the parotid, we are terrified of something called seeding.
Seeding, like planting a garden.
In the worst possible way. If you do a core biopsy, taking a big chunk with a large needle, you might puncture the tumor's capsule. If it's a pleomorphic adenoma, you spill those cells into the wound.
They grow back.
They grow back aggressively. Multifocal recurrence. Instead of one lump, you suddenly have 10 little lumps scattered through the scar tissue. It's an absolute nightmare to fix.
So you just don't risk it.
You might do an FNAC fine needle aspiration, which uses a tiny needle just to suck out a few cells. That's safer. But honestly, if the clinical exam is screaming pleomorphic adenoma and you know it has to come out anyway, many surgeons just go straight to surgery. Why risk the spill?
Okay, surgery goes well, tumor's out, nerve is saved, patient goes home. But then, a few months later, something bizarre starts to happen. The sources called it Fraze syndrome.
Ah, yes. Gustatory sweating. This is one of the strangest complications in all of surgery.
Gustatory sweating, sweating when you eat.
Literally. The patient sits down for dinner, and instead of their mouth watering, their cheek starts sweating. Beads of sweat dripping down the side of their face.
That is just weird. It has to be incredibly awkward. Why on earth does that happen?
It's a wiring error. Think about it. We cut out the parotid gland. So the nerve fibers that used to tell that gland to make spit are now just dangling there, looking for something to connect to.
Okay.
As the area heals, those nerve fibers regenerate, but they get confused. Instead of finding salivary tissue, which is gone, they latch onto the sweat glands in the overlying skin.
No way. So the brain sends the signal, time for lunch, make saliva, but the wire is now plugged into the sweat glands.
Exactly. It's a cross-connection of the autonomic nervous system. The parasympathetic fibers hijack the sympathetic receptors on the sweat glands. It's a total mix-up.
Can they stop it from happening?
They try. When they close up, they try to put a barrier between those cut nerves and the skin. They might use a thicker skin flap or even rotate a bit of muscle in there to block the nerves from reaching the skin.
It just highlights how unbelievably complex the body's wiring is.
It does. The body's always trying to heal and reconnect, even if it gets the instructions completely wrong sometimes.
So, to recap, we start with a painless lump, 2 years of ignoring it. Then this incredible detective work, ruling out stones with questions about lunch, ruling out specific tumors with questions about smoking. They map the danger zone, they go in for this high-stakes surgery,
Peeling a tumor off a nerve that's as delicate as a spider's web.
and hopefully the patient wakes up and they can still smile.
And ideally, not sweating when they eat. It really is a masterclass in anatomical navigation, and the parotid anatomy is destiny.
It's just amazing how much drama can be packed into a 2 centimeter lump. What I think the takeaway here is that you have to pay attention to those silent symptoms. Just because something doesn't hurt doesn't mean it's not important.
Absolutely, and knowing your own history matters. Those questions are the keys to the diagnosis.
So before we sign off, I want to leave you with a thought. We talked about Frey syndrome, that cross-wiring of spent and sweat. It's a glitch.
A fascinating one.
But think about what it says about our nervous system. It says our nerves are desperate to communicate. They are so programmed to connect that if you take away their target, they will literally hack into the nearest available system just to keep the signal moving.
Huh.
It makes you wonder, what other crossed wires are happening inside us all the time that we just accept as normal quirks of being human?
That is a fascinating thought to chew on.
Thanks for diving deep with us today. Until next time, stay curious.
And keep learning.